Hi there, my name's Annabel Crabb and I'm absolutely delighted that you could join us tonight from Federation Square for the Breast Cancer Trials Q&A, which we've done a few of before. And for me, this is very exciting because I am not sitting at my kitchen table being pestered by my kids and my dog. I am sitting in Federation Square with our excellent panel coming to you live. So welcome and thank you for joining us. I would like to acknowledge, before we go any further, the Wurundjeri people and indeed the traditional custodians of wherever it is that you are watching tonight's session from. We have viewers from Australia, New Zealand, all over the place. So I'd like to acknowledge the traditional owners of whichever patch of land it is that you're sitting on tonight. Now, let me tell you a little bit more about breast cancer trials. They are the largest independent oncology research group in Australia and New Zealand, have been conducting clinical trials research into the treatment and prevention of breast cancer since 1978. Now, as we know, all women are at risk of developing breast cancer, and the risk tends to increase with age, with most cases of breast cancer occurring in women over the age of 50. However, and this is the topic for our discussion tonight, young women diagnosed with breast cancer can often face quite unique and significant challenges like premature menopause, fertility and parenting issues, sexuality and body image difficulties, career disruption, and of course, high levels of psychosocial stress. Additionally, premenopausal women are more likely than older women to be diagnosed with triple-negative breast cancer or more aggressive cancers. So, the beauty of this session, the Breast Cancer Trials Q&A, is that we gather the experts and the people with the experience and throw questions from you at them live. Now, I'd like to thank everybody for tuning in and signing up in such huge numbers. We have more than 1,000 people registered and throwing questions in for tonight's session. So I'm going to be addressing those to our panelists, who I'll introduce to you in a moment, and we will begin the business of sharing information, because I know a lot of people who are on a breast cancer journey or love somebody who is. Finding the right information, finding the right expert, assuaging your doubts is one of the hardest and most scary parts of the process. So that's what tonight is all about. Now, today's webcast is being recorded, and all of the technological arrangements are being undertaken by someone that is not me, which means that it is almost certainly going to work. However, if anything goes wrong for you watching the broadcast, or it freezes up or anything like that, don't worry, because it's being recorded and you'll get a link to watch back the whole session. So if that happens, do not panic. Also, if you're looking at your screen, in the bottom right-hand corner, you'll see a little speech bubble sort of icon. So if you'd like to ask a question or comment at any time during the session, just type in the speech bubble, and we have people on hand to answer questions. If we don't get to them right away, we'll have people following up afterwards by email, so be sure to leave your email address. And finally, if you do need technical assistance during the webcast, click on the information icon where you can access live chat support. Isn't technology marvellous? Right. Nonetheless, it is very nice to be here in person with our panellists, who I will get along with introducing forthwith. First of all, on my left, we have Professor Anne Partridge. Very exciting to have you in Australia, Anne. She's a Professor of Medicine at Harvard Medical School in the United States and Vice Chair of Medical Oncology at the Dana-Farber Cancer Institute, where she also serves, because she's incredibly busy, as Director of the Adult Survivorship Program. She leads the program for young women with breast cancer. Hard to think of a better person to have on this panel tonight. Thank you and welcome to Melbourne.
Thank you.
Ms. Laura McCambridge, who is on my right, is a participant in an Australian clinical trial called the Breast MRI Evaluation Study. She's going to be talking to us about her experiences. Welcome, Laura. Associate Professor Nicholas Wilcken, on the end of the panel here, is the Director of Medical Oncology at the Crown Princess Mary Cancer Centre, Westmead in Sydney, and he's also Associate Professor of Medicine at the University of Sydney. Lesley Gilham one of our two Leslies that we have in attendance tonight. We like to have our Leslies in pairs. They're like budgies. They work better together. She is the chair of the Breast Cancer Trials Consumer Advocacy Panel and was a participant in the TEXT clinical trial. Our second Lesley, well, they are both equally brilliant, is Associate Professor Lesley Stafford. And Lesley is a clinical psychologist and consults in the Breast Service and Familial Cancer Centre at the Royal Melbourne Hospital, as well as in practice. And Lesley is an Associate Professor at the University of Melbourne. And finally, another international guest is, well, yeah, she's Aussie. Dr. Hollie Keane, who's a breast surgical oncologist at the Peter MacCallum Cancer Centre and the Royal Women's Melbourne Hospital, Melbourne. She's also a breast surgery research fellow at the University of California, San Francisco. Welcome, Hollie.
Thank you.
Hollie and I also shared a memo about wearing pink and green this evening. I don't know how we achieved it, but we're loving it. So, welcome, panellists, and here's how it's going to work. We had so many questions submitted that we've actually put together a little collection to give you an idea of the kind of breadth and depth and range of the questions that came in from those joining us on tonight's webcast. So I'm going to start by giving you a little look at a video capturing the span of those questions. From those ranges of questions exactly the frame of mind people are in when they're confronting this development in their lives, right? Particularly when they are younger women who have been diagnosed with breast cancer. This fear, uncertainty, this feeling that there are all of these choices to be made, the ramifications of which you don't fully understand. It's a scary place to be, and information and research and expertise is like a beacon for people in this stage of uncertainty and fear. So that's what tonight's all about. And I'm going to start with a question to you, Anne. And as a journalist, I've learned that there is no such thing as a dumb question. So I'm going to start with a really basic one for you, which is, what is young in this field? Like, how do you define a young woman in breast cancer terms?
So I think that's a great question. What population are we talking about here? And it's kind of a moving target and depends a bit on the issue you're speaking about. But in general, most of us, for research or clinical purposes, for taking care of patients, will define young when we think about young women with breast cancer at 40 and under, sometimes 35, and sometimes going up to 45. And the reason we choose these cutoffs, again, depends on what you're focusing on, but historically, the women diagnosed under the age of 40 or so seem to have fared the worst on average in terms of their risk of recurrence. That is changing, and it varies by subtype and lots of issues in treatment. But that's why we've chosen that age to focus on. And then it expands also into what are their unique issues, which I know we're going to spend some time talking about, and things like fertility. Obviously, women in their early 30s care a lot more about their fertility on average than women in their 40s, things like that.
Now, I know that you don't mind being thrown a question on the fly, so I'm going to ask you something that I've just thought of, which is, has there been any change to your knowledge in the patterns of breast cancer among young women as women's average age of reproduction has skewed older over the last 50 years or so?
Sure, and that's one of the reasons why we think breast cancer in young women is going up, because we're delaying childbearing. And for good societal reasons, to go to school and start careers, and for lots of reasons, but that does appear to be potentially one of the reasons that's contributing to higher rates in our younger patients, because not having babies before the age of 30 is a risk factor for breast cancer, including in young women.
Wow. Do people know that? I didn't know that. Is that a... Right, everybody knows that except for me. That's right. That's why I've gathered experts here, and you're not asking me the questions. That is a sound demonstration of why we've taken that approach. Nicholas, about 1,000 young women in Australia will be diagnosed with breast cancer this year. Why are young women often diagnosed with a more aggressive cancer, and are there other differences in the kinds of cancer experienced by younger and older women?
Right, so I think a useful way of thinking of this is first to think of women of all ages, breast cancer, and it's kind of a spectrum, and at one end you've got this aggressive type of cancer where the cells are turning over very quickly and they're not sensitive to hormones at all. And at the other end of the spectrum you've got a very slowly growing tumour that's very sensitive to hormones, that a hormone blocking tablet will stop in its tracks. And then there's the bit in the middle that's a bit aggressive and a bit hormone sensitive. Now for young women, they tend to be down this end. So they tend to be having what you said, this so-called triple negative type of breast cancer that's very aggressive, less sensitive to hormones. They can be anywhere in the spectrum, but it's a tendency to be there. You ask me why, and I can't actually tell you. There's lots of speculation, there's lots of research, we don't really know. And I guess the other important point this is probably the most important thing we've learned about breast cancer in the last 20 years is that there are these different types, and you have to manage them differently. So yes, it's a more aggressive cancer, but we're going to give more aggressive treatment to try and even things up.
And do they ever, is it easy to tell the difference between the different kinds and...
Short answer, yes, once you've got some tissue. You can't by just feeling something. That's why the biopsy is important, and when our surgical colleagues cut it out, we have a very careful look, and we have pathologists who specialise not only in pathology but in breast pathology, and there's various tests that you do, and you can reasonably precisely, obviously we'd like to be knowing a lot more, but we can categorise into sort of 3 or 4 main groups, and that will guide our treatment options.
Right, but there's no grounds for anxiety. I'm just thinking if somebody's diagnosed and they think, well, what if I get treated for one kind and it turns out to be another, or there's not a lot of confusion about that.
It's not precise because we don't know everything, but it is pretty focused now compared to what it was 30 or 40 years ago when we just gave the same treatment to everyone, and now we don't do that.
Okay, I'm going to turn now to you, Lesley, because obviously there are huge ramifications for people's mental health and psychological well-being in this area. Can you tell us a little bit about what you see specifically in young women when it comes to breast cancer compared to women who are older?
Yeah, look, I think there are a range of ways in which the experience of breast cancer is different in young women. I think probably the primary one is fertility. So as anyone who's familiar with breast cancer would know, that treatment like chemotherapy and some of the hormone blocking treatments, it can affect fertility and make it more difficult to have a baby, to conceive after treatment. And so in a younger group of women who perhaps haven't started a family yet or who haven't completed their family this can be a very significant challenge. I guess related to that is the issue of parenting. The younger a person, the more likely they are to have young children, and young children are more demanding in many ways, not in all ways, but in many ways in terms of their care needs and their dependency. And so that presents another challenge for a young person that an older person wouldn't have. I guess a third issue would be around sexuality and body image. The menopausal symptoms that can come with treatment, I think, like weight gain, changes in libido and sexual functioning, I think it's fair to say those are unpleasant for everybody, but they can be particularly unpleasant for a young person who's in sort of the prime of their youth, perhaps establishing a relationship or seeking to start a relationship. And then I guess there's also the treatment-related bodily changes. You could lose your hair, your eyebrows, your eyelashes. There may be scars from surgery or reconstruction, and that may have an impact on femininity and sense of womanhood, which again, older women also have, but arguably this is more salient in a younger population. And I'll just say one more thing, and that's about psychological distress in this group. So younger women definitely have more distress, and distress is more prevalent, emotional distress that is. And I think that's probably because of the issues I've just talked about, but also because cancer is primarily a disease for older people. So for a young person, they don't have the same life experience, the same maturity to deal with that. They're forced into a sort of a holding pattern while their peers are having babies, establishing careers, they're at university, they're travelling. So, cancer is cruel at any age, but I think the loss of opportunity and the sense of injustice is particularly so in a young person.
Thank you, Lesley. Well, sitting right next to you is someone with first-hand lived experience, so I'm going to now ask you, Laura, to tell us a little bit about your story. How old were you when you were diagnosed with breast cancer?
So I was diagnosed last year in September, so that was just after my 31st birthday.
Wow, so diagnosed in a COVID period as well, so a lovely, calm, peaceful, happy time to be getting this terrible news. Tell me, how were you diagnosed?
Yeah, so I just, in a regular check, I found a lump in my right breast, and I'm, thank goodness, a hypochondriac, so I went to the GP the next day. And he said, I think it's probably fine, but we'll send you off for an ultrasound. Went and did that, and the radiologists were like, I think it's fine, but we better get a biopsy just to be sure. And then the biopsy came back. The results were not good. So I started my treatment journey then. I had a lumpectomy and sentinel node biopsy, followed by chemo. And I was just about to start radiation when my gene marker results came back, and so in discussion with my treating team, I thought the best plan was a double mastectomy. So I had that in the end of February of this year, and now just on hormone therapy and finished active treatment.
Okay, so you're smiling, but this doesn't sound... It's a violent series of events, right? To learn this about what's going on in your own body. Did you have trouble believing that this was happening to you at this age?
Yeah, when I got the phone call, I was at work, as you are, on a Monday to Friday, so I just went into a little room and took the call from my GP, and I was just like, are you joking? Like, I don't really have time for this. This is going to be like a huge deal, and it was. It's hard when you're trying to establish your career and just live a normal life as a 31-year-old.
And what were the things about it you found particularly challenging?
One of the biggest things I found challenging was I had to make a decision between a short course of chemo and a long course of chemo, which was like obviously had pros and cons for each, and I had an opinion from my oncologist, but he wasn't swayed too far one way or the other, so I was seeking second opinions. So once I had made the decision, I felt a lot better because I knew what my plan of attack was. But in that period when I was like, I don't know what I'm going to do, am I going to be going through chemo for months, or is it just going to be a few months? Once I'd made the decision, I felt a lot better.
Is making those sorts of big calls when you're in a situation of distress, I mean, you have a bit scientific background, right? Like, so at least you're comfortable in that milieu. But is it helpful to have more or less power in that situation? I mean, do you want your oncologist to just tell you what to do, or do you want, to make the decision yourself?
Yeah, that's a really tricky question. I don't know, I'm all for, being involved in making your own decisions about your own health, but it was a big decision. I think because of my age and my type of cancer, it was just like very similar kind of numbers, if you want to play the number game. But yeah, I guess I would have appreciated being told a little bit more what to do, but now that I've made the decision and I've finished my active treatment, I feel that I made the right decision, so I guess that's a good feeling to have as well.
Just tell us a bit about this idea of getting second opinions and searching further for answers. I know a lot of people find that quite difficult. Did you find that hard to do?
For me, I work in a hospital, so I'm familiar with hospital processes. I have some personal contacts that I reached out to. So I definitely know that other people with receiving my diagnosis wouldn't have those things available to them. I just can't imagine what it would be like navigating the space if you had English as a second language in Australia. It would have been so hard. I was very lucky in that respect to have those contacts.
Great. Now I'm going to turn around to you, Lesley, because when you were diagnosed with breast cancer, you had children. Mm-hmm. How was that experience to have the added responsibility of then explaining to your children what was happening with you?
Yeah, so I wasn't as young as Laura. So my children were 14 and 16 at the time. And I guess they were much more knowing than if you were to have someone like younger children. So I remember it took 6 weeks to get my ultimate diagnosis. And so I just kept telling them I was going to the dentist, which they saw straight through. So as soon as I told them, they knew that I wasn't going to the dentist, but they just didn't know where I was going. I remember talking
to see my second family children.
Yeah. I remember talking to my breast surgeon when she delivered the diagnosis to me, asking her to come home and tell my children because I didn't think I would be strong enough to. But I think we underestimate their resilience, and they were it was a big thing, but they took it all on board and were just grateful that they knew what was going on, I think. So, so it was difficult, but I think because of the age they were at, they could understand a lot more. And then once I started active treatment, I know a lot of people mightn't do this, but I engaged my children in every aspect of it. So they came to chemotherapy sessions, radiation therapy sessions, so I demystified everything for them. And probably gave them a greater understanding of what's involved when someone's diagnosed.
Do you talk, did you have a lot of conversations about that approach with other women who are in your situation who are parents?
I did, and I encourage anyone that I know to include their children at a certain age, of course, because sometimes the fear of the unknown is greater than the fear of knowing. And I think especially, I remember my son, he's an accountant now, but he's very much into his maths, so he was fascinated by radiation therapy. He was all the numbers and things. So I think it took away that fear, and especially around chemotherapy. When you're a child, I think, and you see someone who's having chemotherapy and they've lost their hair, and I can only imagine what goes through their minds. So to take that fear away for them and for them to see it was a needle and it wasn't like they were, covering me in something really toxic, even though it is toxic. But it was a good I think, experience for them to understand it a bit better.
One of the things about being a parent is that you feel like one of your jobs is to protect your kids from painful stuff, and obviously the fear that this terrible thing's happening to their parent is one of the most painful things that you can imagine. So what is it like to juggle that protective duty with your own fear? And
well, I guess I did everything I could to protect them at the time. I said I included them, and in my way that was protecting them from having thoughts, from not knowing what I was going through. I did other things. I touched base with their closest friends, their parents. I touched base with the school, unknowingly to them. And I just encouraged them to talk about things to their closest friends. And as it turned out, in my daughter's group of friends, as soon as I think she was having lunch one day and she told one of her girlfriends, and in her close group there was 3 other of her friends whose mums have been diagnosed. So it sort of opened up this whole conversation for them. But you try to protect them and you try to reassure them even though you have your own doubts at the time.
Thank you. Hollie, if you Google this, there's a million search results about what factors like diet, weight, alcohol consumption, exercise and smoking factor into young women being diagnosed with breast cancer. Given that we have you here instead of Dr. Google, can you give us the Hollie Keane assessment of those factors?
I certainly can. Thank you for that. So I'll just go through those individually. Firstly, you mentioned exercise. Exercise is definitely increased exercise is related to a decreased risk of breast cancer. So the more you do, the better. So guidelines are if you exercise 3 times a week, but it has to be moderate to high intensity. So you've got to be getting your heart rate up or sweating. That decreases your risk of breast cancer. And that's something everyone can do. So it's a good place to start. It also improves overall health, so that's a plus. Diet and weight. So increased weight is associated with increased risk of breast cancer. So obesity and being overweight will increase that risk, especially after menopause, but also for young women. And alcohol consumption. So yes, if you don't like to drink at all, that's very good, it's protective. But it's not all terrible news if you do enjoy a glass of wine. It's also again dose related. So if you drink a lot, that's a higher risk. But say you enjoy maybe 3 to 4 glasses of wine a week, that's only a very small increased risk of developing breast cancer. But so the less, the better, really.
And what about women who are in treatment for breast cancer?
Exactly the same. So there's really good evidence that if you exercise during chemotherapy or endocrine therapy, that can decrease symptoms, and it actually decreases your breast cancer recurrence risk. So it's we all really encourage our patients to try and exercise through treatment to improve your mental health, your overall health, but it also decreases your recurrence risk.
When patients obviously having cancer is a frightening thing. You feel powerless and as though you can't do it, that you're kind of at the mercy of other people's expertise and finding the right knowledge and information. Do you, obviously some people do take up exercise or dietary regimes that they feel, might be helpful. Can you go too far with that stuff?
I guess the answer to that's yes. You probably can go too far with anything. You don't want to be so obsessed with exercise that you're running yourself into the ground, because you've got to listen to your body as well. If you're exercising and you feel like you want to collapse, and you need to have a rest. So you probably can go too far the other way, but you certainly want to incorporate that into the treatment. But you don't want to give yourself too much of a hard time anyway. It's a hard time enough, but to try and take on a few things to try and increase your stamina and your overall mental health and your physical health is definitely recommended.
Thank you. We actually have an audience question now. It's a bit of an exciting, live, actual, real person asking a question from the audience, and it comes from Rose.
Hello. Are more young women being diagnosed with breast cancer, or are we just getting better at detecting it?
That is to Anne Partridge, that question, I think, isn't it, Rose? Are more young women being diagnosed with breast cancer, or are we just getting better at detecting it?
That's a great question, Rose. I think it's the first. We are seeing a bit more breast cancer in young women, at least from the latest statistics in the United States. And given that our demographics, I think, are pretty similar here in Australia, I think the rates are going up a bit. We looked at the last 2 decades, and while breast cancer overall in the US is not going up, in our young women it was going up by about 0.5% each year.
Wow, that's...
Not cumulatively, but each year there was a little bit more. And so we're trying to figure out why. We don't know why. I think some of it's about less exercise than there should be, a little weight gain that's going on in many Western developed countries. Over time, there's an obesity epidemic, at least in the United States, and perhaps also related to some of the delayed childbearing going on in other exposures. So I think that's the main reason. We are getting better at detecting breast cancer and detecting it earlier, but I don't think that's the reason it's being detected more frequently in young women, because most young women don't present with a screen-detected cancer. Most of them present like our colleague over there with a lump or a bump.
So, Nicholas, I'm going to bring you in here for a question that's come in from one of our participants, Rachel. Rachel wants to know whether or not young women are at a greater risk of breast cancer recurrence, particularly if young women have a more aggressive cancer.
Look, I think the most accurate answer to that is that the breast cancer behaves via type rather than via age. So an aggressive cancer in either a young woman or a woman who's not young, I'm not going to use any derogatory terms, is going to be equally bad for you and equally a risk of recurrence. A young woman with the less aggressive type, broadly speaking, will have a similar outlook. So that's the sort of overall kind of statement of it. I think there, nevertheless, having said that, there's a sense that some of the, particularly the hormone-sensitive ones, may be not as docile in the younger woman as they are in the older woman. But broadly speaking, the answer is yes, younger women are at slightly higher risk of recurrence because they're getting the more aggressive cancers, not because they're young.
Right, okay, thank you. Lesley, Stafford. There's a question here from Karen who's asked how you cope with triggers, which Karen gives some examples, like when people say she's brave when she's going through breast cancer, but she doesn't feel that way. Do you hear about that a bit?
Yeah, I mean, I do hear about that a lot in the clinic, and I guess, you know, we all wake up every morning and think that we will go to bed that night the same person that we woke up, and then you have news like a breast cancer diagnosis and your world is turned upside down, and, you know, I guess you really question your sense of stability and security in the world. And so when somebody makes a comment like that you're brave, even though it is coming from a good place, it can sometimes feel very invalidating in terms of how you really feel. So when that happens, you know, I suggest to women that you speak up and say how you do feel. And you can say, well, you know, I don't feel brave, I feel scared or angry or overwhelmed or whatever it is that you're feeling at the time. And also say that you're doing the best that you can. I'd also encourage women to use those opportunities as an opportunity to ask for support. You know, I'm a clinical psychologist, but a terrible mind reader, and I assume your friends and family are the same. So, you know, use that opportunity to ask for support and to say what you need.
This idea of, being a brave battler against cancer is quite loaded, I guess, for a lot of women. And I wonder as well whether the public view that breast cancer survival rates have improved so much over the last few decades that people sometimes on being told this news will say to someone who's had a diagnosis, you will be fine, this is not a death sentence, I mean, how does that work out for people? Because it sort of can have the effect of minimising the very real distress that they feel.
Yeah, and that's the what's reported to me, that it is very minimising. Fears of recurrence are not irrational, they're normal and appropriate, because cancer can recur. So when we're out and about in a culture that's positively awash with toxic positivity, it's really hard when you're told to just be brave, just be strong, just be optimistic, and then everything will be okay. Because I guess the corollary of that is that when things aren't okay, you weren't strong enough, you didn't fight hard enough, you weren't positive enough, and that's not actually how it works. This is not the playing fields aren't even.
Laura, I see you nodding along there. Did you have a bit of experience of this, or?
Yeah, it's just when people, I hate the word must, like people come up and they say, oh, you must be feeling this way, or you that must have, I'm like, you actually don't know. So I think a better framing would be, to me that would feel like this, and then I can respond if yes or no. But yeah, I hate that you must be, feeling a certain type of way.
Did you cop any toxic positivity? Such an amazing phrase, isn't it?
No, I don't think so. I probably am the toxically positive person in my situation.
You're the problem.
Yeah, I'm the issue. I did. Yeah, my GP did say, you've got such a good attitude. People with your attitude always do fine. I was like, okay, well that's good, but doesn't really seem medically sound.
Hollie, do you think this idea of attitude is a factor? Are you a subscriber to that view?
Yes.
You are? Okay.
I am. I think a positive attitude goes a long way.
Right.
I don't have it.
Give us the
I don't have the
clinical-
literature behind it. There's no hard evidence, but I'm a believer.
Okay.
Yeah.
So you think you see different results in people depending on their...
Well, now you're really pinning me down, but
Well, I'm here to pin you down.
I personally think that a positive attitude really does help.
Right. Any other eyebrow raise here?
I think a positive attitude makes life better.
Yeah.
And
True.
it may lead to you more diligently doing things and following doctors' advice and so on. But if you have a really cold, hard look at it, and this has been done by a famous oncologist who's in the audience, and you ask women how optimistic they feel at the beginning, and you come back 10 years later and see in whom it has recurred and whom it hasn't, it doesn't make a difference. Mm-hmm. So I think I'm not saying it's a bad thing. It does help you behave well and cope well, and there may be some medical advantages because you may end up seeing the doctor, more regularly, or taking the tablets instead of stopping taking them, and so on. So it might have that kind of effect, but it doesn't have a sort of cosmic effect on the universe.
Right.
In my opinion.
Anne?
I also think you can't tell someone to have a positive attitude.
Right,
So I
yeah.
think positivity has to come from within if it's there, and if it's not, and I'll defer to our psychologists to help us with this, you need to meet people where they are and support them in the ways they need it. And sometimes they don't need a cheerleader, and they need support in other ways. And I think forcing positivity on someone, especially when it's not been shown to improve outcomes overall from a cancer standpoint, sure, that person might feel better that's positive, but the person who doesn't feel positive might not feel better if you try to make them feel positive.
There is nothing more annoying in the world than being told to be more positive than you're feeling, right? Yeah.
And also there may be times when optimism is a good thing, and there may be times when pessimism is a good thing. If you're so optimistic that you say, this cancer's never going to come back, I'm not going to have any tests, then obviously that's not such a good idea. You know, the classic thing is, do you want your pilot to be an eternal optimist? No, you do not.
I'm going to come back to you, Lesley, because there's a question here from Paula who has asked how to manage this fear of breast cancer coming back, particularly, she says, when a lot of media stories show young women with breast cancer.
Yeah, look, it's fear of cancer occurrence is probably the number one unmet need in women with breast cancer. And I think it's probably the main reason that women seek out psychological services after the end of their primary treatment. And it's really hard to get away from it because social media is full of it. You can't go down to Woolworths and buy a box of biscuits without seeing a pink ribbon. So it's kind of really hard to not be reminded about your breast cancer. You only need to perhaps look down at your chest or look at other bodily changes. So, look, I often have to remind my patients that it's funny how you never see in the media anybody who's doing well after breast cancer, and that's not because they don't exist. It's just because it's not clickbait. So the fact is that most people actually do okay. There are certainly tough parts and you know, it's up and down, but it's not how it's portrayed all the time, predominantly in social media. But what to do about fear of cancer occurrence? Well, number one, unplug from social media. If you have questions about your prognosis, your cancer, ask your team, ask your treatment team, ask them what signs and symptoms to look out for, what sort of surveillance should you have. Understand your own risk, understand things you can do, like Hollie was saying, to reduce your risk. Some of the other things that you can do when you worry about cancer coming back is remember that that's quite normal. It's not an entirely inappropriate thought to have, but be mindful of your thinking. Watch the propensity to catastrophize. Remember that a thought is just a thought, it's not a fact. Just because you think you may have a recurrence doesn't mean you will have a recurrence. So kind of being mindful about how you think is also really helpful. Something else that I sometimes talk about is reminding yourself of other times that have been really difficult for you, your primary diagnosis, getting through that, and identifying those aspects that were really helpful for you to get through that period. So what supported you? What are your strengths? And if you had to go through something really tough again, like a recurrence, could you draw on those strengths again? Where are the sort of gaps that you need to patch? Remind yourself that you've gotten through something tough already and you can probably do something like that again. There are also a range of resources out there. BCNA has a fantastic suite of resources on fear of cancer recurrence, some short videos. Lots of reputable organisations have fact sheets, and so there's a lot of support that's out there for you. But if you're finding, as someone who's had breast cancer or who has breast cancer now, that your thoughts about recurrence are interfering with your ability to parent, your ability to work, that you're hypervigilant all the time and interpreting every sensation in your body, for example, as a sign of recurrence, or you're finding it really difficult to plan for the future because you're certain that you'll have a recurrence, then I'd say that it's probably time to have a discussion with your treating team or with your GP and to look at getting a bit more formal support, formal clinical support.
Thank you, Lesley. Turning to you, Lesley, your cancer was 10 years ago. Mm-hmm. Where did you find yourself on this sort of doom-scrolling spectrum? Did you follow Lesley's advice to get off social media? Or
I think as you get further away from your original diagnosis, you get get better at controlling your thought process. But in saying that, there's not a day that it doesn't cross your mind. And I know a lot of clinicians don't necessarily understand that, but you have a physical side that reminds you, because of the increased occurrence of breast cancer, you have friends who get diagnosed. And so it does cross your mind quite regularly, and I don't think that ever goes away. It just goes from thinking about it for, say, 30 minutes to thinking about it for 30 seconds. So you get better at being able to, I guess, put it to the back of your thought process and move on, and I guess probably don't let it define you.
What about this phenomenon that I hear about called Scanxiety, which is a peaking of worrying when you're due to have a scan?
Absolutely. That is always there too. So it's not necessarily always there for everyone, but I always think when you're there having your annual mammogram or your ultrasound, you're trying to read their faces to see if they're seeing anything, and of course they're very professional and don't give you anything. But there is that increased, heightened fear around those times, because as many sort of things that you can do for yourself to try to see if there's anything happening, it's those, I guess, screening times where it becomes more fearful. And there's also you become a bit paranoid, and I think that dissipates as you get further away too. Every pain you think could be a recurrence, and it's trying to manage all that, I think, as well. But you get better at it, I think, as you get down the track.
Thank you, Lesley. Now, Nicholas, I've got a question for you from Lynn, moving into this area about fertility, particularly for young women. Lynn wants to know what options are available for young women when it comes to wanting children after their cancer treatment and preserving fertility.
So there's three main ways. The most effective, the most likely to result in a successful pregnancy and delivery, but also the most fuss, is if you have a partner, you can go through a cycle of IVF to harvest eggs and fertilise those eggs and stick them in the freezer, somewhere where you won't lose them, and that's sort of the most effective thing, but it's not always possible. You mightn't have a partner. It might be hard to organise the IVF. There might be some perceived hurry in starting treatments, although it's usually not that urgent. The second thing is, if you don't have a partner, you can do the same IVF and save eggs, and that's not quite as guaranteed of producing a successful pregnancy, but that's good. And the third best option, but the easiest one to do, is to take some medication that closes down the ovaries. And there are studies done by our group and other groups that show that if you have a monthly injection that stops your periods and essentially puts you into menopause, it puts the ovaries to sleep, and they seem to be less affected by the chemotherapy. So those studies show that more women get their periods back and more women can go on to have babies, although it's by no means guaranteed. So if you want the best guarantee and you have a partner, it's the fertilised egg. But there are those three options. Miss Anne has any others? No. So yeah, that's what I would say. And we frequently have this discussion.
And you can wake up the ovaries afafterwards, just with a...
Yes. Yeah, you just stop
with
the
a
treatment.
kiss or something.
Yeah,
Sorry.
yeah, sort of, almost. So for we doctors, that's a critical thing that you always have to ask a young woman: have you had children? Were you planning to have more? What do you think about it? And so on. So it's part of the conversation, which, as you can imagine, I'm sure Laurie, you got all these other things going on in your mind, and then on top of that, the doctor starts talking to you about children. But it's a really important thing to have you may decide not to do anything about it. That's fine, but it's important that you know what your options are before you start chemotherapy, if you've got the type of breast cancer that needs chemotherapy.
So how do you sequence these issues for young women who are experiencing shock, confusion, fear, and you're saying, look, hey, here's another issue that I'm just going to park on your front lawn?
Yeah, look, it's tough. I mean, I guess, and there will be different styles of doctor and different styles of patient, but on average, I guess for me, the most important thing is So I'm a medical oncologist. I'm the person that wields the chemotherapy and the hormone treatments and stuff. So the person's been sent to me because the surgeon or because someone else thinks that maybe they do need chemotherapy. So that's already a select group. So I guess my feeling is if I think, yes, this woman really should have chemotherapy to maximise her chances of being cured, then the most important thing is for me to explain why that's the case, what's involved, and why I would recommend that, although ultimately, obviously, it's up to you. So you've got to do that bit first. And then you've got to do these extra bits. And I guess my mind is probably in the background preparing for that, because I've already asked them a few questions when I first meet them. You know, are you working? Who's at home? I say. I don't say, are you married? Because I think that's the point. Who's at home? And you get a sort of clue of how it all works and whether they've got children. So I'm probably subconsciously already thinking that through.
You have a high degree of emotional intelligence. We were just discussing this earlier.
Thank you.
Sorry, I'm just now going to cough awkwardly. That's not because of our exchange, it's just because I've got a frog in my throat. While I've got you and your emotional intelligence, Nicholas, I'm going to ask you a slightly scary question, which is, does hormone treatment or contraceptives increase the risk of breast cancer in young women?
So when we're talking about oral contraceptives and breast cancer, there's two parts to the answer, and you have to listen to both parts. Okay, so the first part is that oral contraceptives very, 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 very slightly increase the risk of breast cancer. And the second part of the question is that is massively overwhelmed by all the good things that oral contraceptives do for you. Obviously not being pregnant when you don't want to be pregnant, but oral contraceptives also massively reduce your risk of ovarian cancer. So don't stop taking the pills.
Anne, you're nodding along.
I concur completely. And I always say to people when they ask me, my patients will say, well, what about my daughter? Can she take the pill now that, you know, I've been diagnosed with a breast cancer? And the other really critical thing, beyond the weighing of the pros and cons, slight increased risk versus all of the potential benefits of oral contraceptives, but the other is a lot of the increased risk, you have to think about what their risk is at that time. So if a person is 22 and 23, their risk of getting a breast cancer is very small. Even in a genetic mutation carrier where we give them to those patients because it reduces their risk of ovarian cancer, which is much higher than it otherwise would be as well. So it's tricky and it's a personal decision, so I would definitely have that person talk to their doctor, but remember that it's also a proportional increase in risk. So a doubling of the risk could still be a very low risk for that young woman. It's not double either.
No, if you do the sums, it turns out to be a handful of cases per 10,000 women, something like that.
Sticking with fertility for a minute, I want to ask you, Laura, you know, one of the most confronting things for young women about breast cancer is suddenly having to deal with all these questions that you lazily thought you'd be putting off for years, like lots of contemporary women. So questions like fertility and early menopause. What's been your experience of dealing with these huge issues, and how did you and your partner manage it?
Yeah, so when I first heard the word chemo, my mind did jump to fertility because I vaguely knew that it could be affected. Before I started chemo, I had to decide what I wanted to do, another decision to make, and I went with IVF, so I froze some little eggies. So that was presented to me as an insurance policy with the hope that I would be able to conceive naturally in the future. It's nice to know that they're sitting there waiting for me if I need them. As far as the actual procedure, I'm okay with needles, but that was a lot of needles and a lot of visits to the hospital, and the scans are invasive, so it wasn't my favourite part. I don't have a favourite part, but my partner's super supportive, so that made everything a lot easier.
And that process involves a whole lot of hormonal, activity, right? Like, I mean, how did you incorporate those kind of mood-altering processes on top of everything else that was going on in your life?
Yeah, I'm not sure if I did get any mood changes. It's so hard to pull apart what was making me feel a certain way when so much was going on. But yeah, I know that does affect some women quite a lot. Yeah, for me, I don't know, maybe others would be able to comment on that better, but I didn't feel like I had any big mood changes.
And how long did that process take for you?
Not a long time. I only had to do one round because they were able to get a good crop. So
it's impossible to talk about this without feeling like a chicken. So you know.
I know some of the terminology. I was like, wow.
About harvesting.
Yeah,
harvesting. Yeah.
They're like, oh, yeah, today's the date of your harvest. I was like, just don't talk to me
Find
about
a different verb.
Yeah. Yeah. I think it was like a couple of weeks. Yeah, so I didn't have to wait too long to start chemo, luckily.
Great. Okay. Thank you for sharing egg-related material with this group of total strangers. Your participation is very generous, thank you. Hollie, we've had a question in from Janet who wants to know about breast implants. She says, given stories in recent years about the safety of implants, what options do young women have for breast reconstruction?
Okay, yes, so definitely probably referring to the scare with implants is that's, you may have heard of an issue called BIA-LCL, which is breast implant-associated large cell lymphoma, and that sort of is more associated with a type of implant which is called a textured implant. So if we're thinking about breast implants, there's two main types. One is sort of a smooth implant, which as it sounds is smooth on the outside, and the textured implants are these ones that are more associated with this very, very rare disease. That's important to emphasise. It is very rare, and it wasn't really documented until about 2011, and since then we've been using less overall of these textured implants and more of the smooth ones. So the rest of the question, so what the options for reconstruction? So overall there's two overarching types of reconstruction. So autologous means using your own tissue, and there's various options for that. You can use abdominal skin and fat and make a very natural looking, well perfused breast. We can use parts of muscle as well. Or the other type is an implant-based reconstruction with a prosthesis, so that's a foreign body, but plastic surgeons are very good and breast surgeons are very good at making a nice natural looking implant. And yeah, so just to emphasise that the risk is very small and we're not using them so much anymore.
Okay, thank you for that rundown. Janet will be pleased. Jodie has asked, is there a link at all between breast density and breast cancer?
Yes, there is a link between breast density and breast cancer. Density, basically breast density reflects the amount of glandular tissue in your breast. So glandular tissue is the milk ducts and the milk glands, and the connective tissue or the fibrous tissue around it that holds it all together versus the fatty part of your breast. So the more glandular and connective tissue you have, the denser your breast, and if your breast is more fatty, then it's less dense. Right. And the way density we measure that is basically on a mammogram. And so if your mammogram looks more white, the breast is more dense. But if it's darker, it means the X-ray beams are penetrating through the fattier tissue, and the mammogram looks darker. So the issue with that is it can make the mammogram harder to read. So a whiter mammogram can hide small lesions or earlier lesions, but there is certainly a risk with having increased density and developing breast cancer.
Right, but that is more about the capacity to spot it than it is about the risk of...
It's a bit of both. So it can be harder to see a lesion because cancers can look white on a mammogram, but there is also evidence that it's associated with increased glandular structures in the breast. And certainly, that's something we're looking at this week in the breast cancer trials. We're looking at looking at density to incorporate that in how we screen women, and without wanting to shove my optimism on everyone, we can do better at screening and personalising that sort of thing, and breast density is a part of that, and it's about empowering women and letting them know what their breast density is and what their risks are. It's not a one size fits all type of thing, and breast density is one of those factors, and that's something that we're looking at this week.
Get to know your breast density.
Yes.
I have not done that, but I'm now thinking about it.
I can help you out.
Thank you. Okay. See you backstage afterwards. Now, so,
Not personally.
so Anne, a bunch of people watching from home have submitted questions about when should young women start screening? And there's a lot of frustration about the fact that breast screening in Australia is not free for those under 40. Can you tell us a little bit about the US experience of this, and does the US have a model of care for breast cancer in young women?
So I don't know which one's more controversial, the breast density and what we do with that, or when we start screening.
I think you should consider yourself at liberty to be controversial.
Okay, thank you. So in the United States, historically, initially it was 35 was the number for screening, the age. And then as the data came in over the last several decades for the very young women, it became more and more clear that there does appear to be a benefit from mammograms for women between 40 and 50, and yet there was a big discussion nationally about whether the risks of the mammogram during that 40 to 50 range were worth it. And this was based on good randomized trials, but of course there were limitations like there are to all studies. And these are studies that are international, many of them in different places around the world. And so in the end, our radiology society said 40. Our government body that was there to kind of weigh the pros and cons a little more intensively said 50. And then the American Cancer Society, which kind of lives in between, said 45, literally to split the difference.
Yeah, wow.
And so now we weigh in on starting screening at 45, although of course there are exceptions. And many women do get mammograms before 45. I always tell people to kind of get started in their early 40s at least, unless they have a strong family history or they have a known hereditary predisposition. So I think the really important thing is to kind of know your risk as best you can, and know your family history. If there's any doubt, go and get, you can do these programs online and go and get, genetic testing and counseling if that's appropriate, talk to your GP. And then the other thing is to be aware of your own breast health. That's not screening, that's more about early detection, but I think it's all part of a package. And if you feel anything or there are any symptoms, you want to be evaluated. I think the biggest message for any young woman out there is, or anyone with breasts out there is, no one's too young to get breast cancer.
Okay, so do you think there's a role for better education of really young girls about the risks and symptoms of breast cancer?
That's another tricky one.
Right.
So I think there is that awareness, but how young do you go in terms of actually educating people when there are so many other things to educate them about? I'm a little bit more of a proponent of educating them about, diet and exercise in a healthy way, being healthy, taking good care of their temple. They're going to have one body, like one car for the rest of their lives. Take good care of it. I don't know that I would focus on breast cancer because the risks are so low at that age. I think later on, well into college and beyond, would be a time when women should just know that if you ever feel a lump, get evaluated. But the vast majority of lumps will not be cancer in very young women, including women, in their 30s. So it's a tricky balance. But I think women just need to be aware. And when someone comes to a doctor and says, I have this lump, they need to be taken seriously. For so many years, they weren't, and we saw a lot of tragedies.
Nicholas, a lot of people have asked the question of what's the best way to detect breast cancer in young women and what resources are available to help them with self-checks.
I think Anne's sort of largely dealt with that. I mean, I guess I think the thing to emphasise is that there's young women who don't have anything to suggest that they might have one of those mutations like Laura does, the Angelina Jolie thing. So if you don't have a family history and so on, then your overall risk is very low, and screening doesn't really work. The younger you are, the less good mammograms are anyway. If you're under 40, and particularly if you're under 35, then mammograms don't work very well, and you're more likely to make a mistake and end up having to have a biopsy that you didn't really need, etc., etc., etc. So
Right.
that's 95% of women. Then there's 5% of women who do have these genetic changes, or at least have a very strong family history, so they might have that, and that's different. And those women, if they're shown to have one of those mutations, meaning they've got a very high risk, might decide to have a bilateral mastectomy, but if they don't, then they can be enrolled in plans. The big hospitals around the country have these specific genetic type clinics where they can qualify, for example, for MRI scans and be monitored in a much more intensive way. But you wouldn't want to do that in the normal population, because you'd spend $1 gazillion on a gazillion MRIs and find almost no cancers and cause all sorts of havoc for those women. Does that make sense?
It does. It makes a lot of sense. To you, both of you, really, Anne and Nicholas, we've had a question in from May, which is just a really good basic question. What are the early symptoms of breast cancer? We think about lumps, but are there other things that...
Can we start?
Yeah.
So lumps and bumps, skin changes, rashes, just redness or swelling can also be a sign. Of course, that happens in young people, especially if they're nursing and they can have clogged milk dust. That's actually one of the hardest kind of to detect things. So nipple discharge, especially bloody nipple discharge, and then swelling under the arm. So in the usually the lymph nodes. Those are the main ones. And the other key thing is people will be told, breast cancer doesn't cause pain in the breast. It can. It doesn't usually present with pain, and breast pain most commonly isn't cancer, but just because it's painful, don't think that it can't be cancer. That's been a myth that we've had to kind of, initially people thought, pain, I'll go get checked out. Then people were told, it's not painful, you don't need to do it, or it can't be painful, but it can. I don't know if you...
I agree, and I guess the only other thing is, obviously you don't want us to delay a diagnosis, but it's not urgent as in urgent in the next few days. So if you think there's a lump, you can watch that for 2 or 3 weeks and then say, okay, it's still there, I'm going to the local doctor to get checked out.
Okay.
And I echo what Anne says, that it's very rare, but one of the toughest things is women who are breastfeeding get some cellulitis, some redness, have antibiotics, and it happens 4 or 5 times, and eventually you find that that's cancer. So if you're on your 3rd course of antibiotics, ask a question.
Yeah, okay.
I just want to add one other thing too, which is most lumps and most changes in young women and in premenopausal women will not be breast cancer, but you still need to follow it. Make sure it either goes away or is stable, or get an evaluation. So you don't want to go away and say, I'm totally fine, if it hasn't gone away. On the flip side, in a postmenopausal woman, it's a little bit of kind of guilty until proven innocent, because more frequently lumps will be a problem there. Not all of them, but it's a very different thing once someone's gone through a menopausal transition. And a premenopausal woman, even though we're dealing with breast cancer in young women, but that's not the usual of what a lump is. But since it's possible, we want to err on the side of at least following it and potentially, getting more evaluation in a biopsy.
Okay, so there's a generationally declining case for demented optimism.
Correct.
Right, okay. Lesley, back to you with a question from Louise, who asks, what support is available for young women who are experiencing psychological issues after diagnosis and treatment of breast cancer?
Okay. So there is quite a bit of support out there, and it depends on what you need. So most or many women can manage with a combination of support from family and friends, and also access the resources that are available again from BCNA. They have webcasts and podcasts and all sorts of fact sheets. There's an online sort of network of women who you can connect with and share stories, and that's often very validating and very reassuring to connect with someone where you don't have to explain what you've been through, because they really get it. Cancer Council similarly has a information and support line that is staffed by, I believe, nursing staff, and you can give them a ring and discuss how you're feeling, I guess, for more transient types of distress. If you're still under the care of a treatment team at a hospital, I would raise the issue with your treatment team, with a nurse, with a doctor. And I sort of want to emphasise that mental health is health. I say this a lot in forums like this, but for me, there's no real physical health and mental health. And if there's one thing you take away from what I say tonight, it's this: that speak up if you are distressed, because mental health is not a luxury or an added bonus. It's an integral part of your recovery and of you doing well and having a good quality of life. So if your distress can be dealt with by fact sheets and resources, great. If your treating team has access perhaps to a psychologist or a social worker on site, also good. If your distress can't be managed in that way, then again, speak to your GP. Currently, under the current Better Access scheme with the pandemic plan, you are eligible for up to 20 sessions, Medicare rebatable sessions with psychologists in the community from the 1st of Jan until the 31st of December. And so I would encourage you to make use of those. The stigma around mental health exists, and I would encourage you to take steps to break down that stigma by asking for help if you need it.
I think there will be a few people watching tonight who are here because someone they love, a young woman, has breast cancer. And I think Connie, one of our questioners, is probably representative of those people when she asks how she can support her young friend going through breast cancer. I know that everybody's different and everybody's in a different place, but are there some good broad rules of thumb for being helpful in a way that is not annoying, upsetting, traumatic or pestilential to the person concerned?
Yeah. So it's a great question, Connie. I think, for your friend, she wants to probably be listened to. When we love someone and they're in trouble, they're distressed, I think our sort of immediate response is to say, don't worry, it's going to be fine. Just do this or just do that, and that's usually just be strong, just be positive, and it will be fine. And that again can feel quite sort of invalidating when really what you want is just to be heard, to be given a bit of space to talk about how you're feeling. If you can, as a friend, if you're in a position to offer practical support like food rosters, taking your friend to and from appointments, or if you can, sitting with her in her appointments, being a second set of ears to listen to what the doctors and nurses are saying, to accompany her to chemotherapy, that would be great. What I think is also really important, though, is to remember that this diagnosis that your friend has, it's something that's happened to her. It's not who she is. So she has a whole life outside of this diagnosis, and yes, it's taking up a huge amount of mental burden and physical energy at the moment. But I think one of the things that a friend can do is keep the woman with breast cancer engaged in her life. Invite her to go for a walk. Say, let's go for a coffee. Remind her of all the things that she has loved to do before this happened, and things that she will love to do again. I guess the only thing I would add to that is keep up the support. What I observe so often and hear so often is that friends are really available and family are really available during the thick of treatment or at diagnosis, perhaps when a woman is having chemotherapy. But then as primary treatment comes to an end, there's this sort of a perception that, well, treatment is over, she must be fine. And the support, the meals, the dropping the kids at their swimming and ballet lessons, all that sort of stuff drops off. And women can end up feeling quite abandoned and lonely. So if you can keep that support consistent, keep it up, I think that would be really appreciated.
Good on you, Connie, and thanks, Lesley. I think we now have another audience question. It's from Carly, who's standing up right now.
Thank you. My question is, when is it appropriate for young women to have genetic testing to check their risk of developing breast cancer?
Hollie, do you want to take that one on?
Sure. Hello. Yeah. So genetic testing, when someone is thought to be at high risk of having a genetic mutation, an inherited mutation, they're offered genetic testing. So that's firstly when there's a known genetic mutation in the family. So a mother, a sister, or a relative that has a known genetic mutation, then we automatically test these people. The second category is women that have a high risk family history. So when we're thinking about a high risk family history, most women, as we've said, will have someone in their lives or know someone who's been affected by breast cancer, but a higher risk for a genetic mutation is first or second degree relatives on the same side of the family, so maternal or paternal side, and at least one diagnosed at a young age. So that's a higher risk, and that's when genetic testing is offered. And there's a few other higher risk situations, such as if there's a family member who has had a certain type of ovarian cancer that is associated with the BRCA1 or BRCA2 mutation, and those women tested as well.
So we've had a number of questions through from mums who've had breast cancer and worried about their daughters, right?
Yeah.
So what is the actual process for genetic testing? I mean, how do you go about it? Do you get a referral from your GP? How does it work?
Yeah. Yes, so that's definitely different in the States than it is here, but we're sort of heading that way. So at the moment, the process is a GP can refer any woman to a familial cancer clinic. So that's generally, at a hospital where there's a family cancer clinic, and then a genetic counsellor gets in contact with the individual and takes a family history and sort of assesses their risk. And if they're above a certain threshold, greater than 10% of having a genetic mutation, then they're offered genetic testing. More recently, there's, as it is in the States, there's medical genetics companies that are now starting to make it a lot more accessible to get a genetic panel of testing. There's companies such as Invitae and Colour, I think, are sometimes used here in Australia. And that process is you get online and you can you do have a sort of an intake questionnaire, or your GP or someone like me can actually download the forms for you, and then it's a simple saliva test that gets in the post to you, and it can be done by yourself at home or by your doctor, and then that gets sent back to the company, and it takes about a couple of weeks, I think, is the average for that saliva test. It can also be done by a blood draw, and then depending on the results of that, there's counselling either way. So if there is a genetic mutation or defect found, then the individual will get counselling and recommendations on how to manage that risk. And certainly if it's a negative test, then we give information about that as well.
Thank you. You are a fountain of information. We are unbelievably only about 12 minutes away from the end of our session, so I'm going to start a rapid fire round of shooting questions at you so that we can make sure we get to all the great questions that our participants have asked this evening. Anne, we've had a question from Sally, who's asked about early menopause as a result of having treatment and breast cancer. Do you have advice on how you deal with these side effects?
Sure, and it's common to be put into menopause by our treatments these days, especially for our very young women, because we've now found that for our very young women, many of them benefit from that shot that preserves ovarian function. Well, we use it for treatment too, and when we do that, whether or not they get chemotherapy, we often do it for somewhere between 3 to 5 years. And so based on clinical trial work led by one of your own, Prue Francis, right, in the SOFT trial. So that's how we showed the benefits of the ovarian suppression. So rah-rah to Australia. But I'm a cheerleader at heart, positive too. And clinical trials pro. But seriously, so we treat people with ovarian suppression often, especially our very young patients or people who have higher risk disease, and that brings on a lot of menopausal symptoms, as do some of our other oral endocrine agents. And then, of course, if chemotherapy causes either temporary or permanent menopause, that can cause some of these hormonal symptoms. And they're usually hot flashes, vaginal dryness, sometimes discharge, menopause, moodiness, sometimes weight gain. And the way to manage it depends on the symptom. And there are behavioral management strategies, some of which include literally dressing in layers, having cold packs and fans. And I even have a couple who have one of these fancy beds where half the bed can go cold while the other half is normal temperature.
Oh, I want one of those.
It's pretty nice. So behavioral ways of managing it, things like yoga, acupuncture, mindfulness can really help people because there is a big mind-body connection with a lot of these symptoms. To help manage them and how one reacts to them. And then you can go all the way to, and for vaginal things, there's moisturizers and lubricants and even physical therapy. And then you can go to medications. There are specific medications that can help, in particular with the hot flashes or the night sweats that can go on.
I can see you nodding, Lesley. What was your experience like?
It was a while ago now, but I was fortunate enough to be on the follow-up trial to the soft trial. So I was on the TEX trial, which was also run here in Australia and New Zealand, and I went into menopause overnight with one of those great injections. So I had fairly severe side effects straight up, including mood changes, if you ask my husband. But then I don't know, like I was on an aromatase inhibitor as well, so I don't know how many of the side effects were caused by the menopause or were caused by the treatment. But I persisted with everything, and I didn't actually have any help to cope with them, but they did dissipate over time. So I would encourage anyone to just hang in there because they do dissipate, I think, over time. And then you're left with some longer lasting symptoms, but in my personal case, they're quite manageable and things. So yeah. So.
Thank you. What about you, Laura? Did you have side effects?
Yeah, I definitely experienced those hot flashes, and I'm normally one of those people who has like freezing cold hands, and you have to be like, sorry about my hands, and that was just the complete opposite. Just sweating in the middle of the night. Some really bad night's sleep. But that, as Lesley said, has dissipated, which is really good. I've got a little bit more joint pain. I'm very conscious of, keeping up with weight training and resistance training to try and target that risk of, osteoporosis and things like that in menopausal women. Those are my two main things.
Okay, thank you. We've got a question from Therese, which I think I'll send to you, Lesley. Therese wants to know what support and information is available for young women, particularly in relation to the long-term effects that breast cancer can have on fertility, but also on having a normal sex life.
Thank you. So as Nicholas was saying, right at the start, ideally the treating team, the medical oncologist, will have a discussion with the woman about her fertility preservation options. Sometimes there isn't time to do anything about that, and things are moving really quickly at that stage, and it's not often until much later that that grief is realised. And I think that may be the basis for Therese's question. But at diagnosis, in addition to the support that your oncologist can give you, there's also a fantastic fertility decision aid that was developed in Australia by one of our local researchers, Michelle Peet, and that's available as well through BCNA. It's very detailed, gives a lot of information specific, obviously, to breast cancer. There are also, the issue of fertility is going to come up and keep coming up through survivorship, and I encourage women to speak about it, to acknowledge that grief, if that grief exists, whether you do that through counselling and again, back to the GP if that's the appropriate course of action. Again, and I'm a bit like a broken record, there are wonderful resources available on the BCNA website. On the Counterpart is another organisation for women with cancer here in Australia, And if you look at the Counterpart website, there's a navigator that takes you to information about fertility and also about sexuality. I do, again, want to emphasise women to speak up about their sex life problems. So many women will come and report to me that they've never raised it with their nurse or their doctor because they're embarrassed, or they have a perception that they should be grateful just to be alive, and that anything beyond that just doesn't seem appropriate. And to be fair, in some cases, the clinicians don't necessarily ask, is everything okay in your sex life? So unfortunately, the onus does then fall on the women to speak up. So yes, there are a range of resources out there, booklets, webcasts, podcasts. If that's not enough and the process is clinically distressing, you can speak to your GP. And also actually on the BCNA website, they do have a link to a directory of sexual wellbeing therapists that can be of benefit as well.
Thank you. I'm about to hit our researchers with an unforgivably broad question, which is, you've all done a great job tonight of kind of giving us a mud map of the issues, treatments, symptoms, and all of that. What I want to ask you now is a big question about where research is at into breast cancer in young women and where you see it going in the future. I'm going to start with you, Anne. What excites you?
Well, I think the most exciting thing is all of the breakthroughs that we've seen even in the last year in terms of opportunities for additional therapy for some of those more aggressive breast cancers in women living with advanced disease as well as in women with early stage disease. And when our young patients present, as you heard so eloquently from Nicholas, it's not that they have worse disease, it's that they present with a different mix of disease that tends to have the more frequently the more aggressive types. And so the more that we can combat those aggressive types with the women who are dealing with it, the fewer women will hear from it again, or will live longer with advanced disease. And so I'm mostly excited about all the breakthroughs that are coming, and I just want to keep them coming. Okay, that is a great positive note to conclude on.
I can be positive too. So yeah, I think things are moving faster, aren't they? 20 years ago, something happened every 5 or 10 years. Now something happens every 6 months, seemingly. The drugs are getting smarter. Look, I think essentially from a drug treatment point of view, what we want is drugs that work better and hurt less. And we are getting there. We're deeply imperfect, as all of you, as Laura knows. But we are getting there, and we do have some smart drugs that work really well and don't hurt much at all. So that's where we're going.
Hollie?
A couple of things. I completely agree with what's already been mentioned. I mean, I am a surgeon at heart, but the really exciting thing is that we are able to now do less surgery and cause less long-term complications than we have historically. Many years ago we started taking whole breast and muscle and all the lymph nodes and leaving people with, long-term things such as lymphedema. And now we know that we can personalise medicine and surgery better than that, and we're getting much better than that. Optimistic, but we've still got some things to work on as well. But that's a really exciting thing, being able to de-escalate management and making it more personalised.
What about you, Lesley? Do you think that applies to you? Are we getting better at helping young women through this experience?
Look, I think everything that the doctors have said is great, and I do remind the women I see in the clinic that things are moving quickly. Because they often also worry about what their children will have to deal with if this is a hereditary breast cancer. For me, what's really exciting in the context of all these really exciting developments is the recognition that patient-reported outcomes are so important. So it's great to be looking for effective treatments and to reduce treatment-related morbidity, but we also have to consider the patient's perspective in terms of the impact on her quality of life. And what's great about all the new trials is that they take that really seriously. So, sometimes new treatments, you need to think about whether reducing the length of a treatment is actually going to make a woman worry more about her cancer coming back. Is it going to shoot her fear of recurrence right up? Because radiotherapy used to be 5 weeks and now it's only 3 weeks. So what's really exciting in that space for me as a psychologist is that emphasis on what the women think, what the consumers think. Yeah.
What about you, Laura? I mean, you're what this panel is all about, I guess, and listening to all of these perspectives this evening, what does it make you think about and hope for in terms of young women who are diagnosed with breast cancer in the future?
Yeah, I guess in a perfect world, all of these treating clinicians would be out of a job and we wouldn't have a Q&A panel like this because we wouldn't have diagnoses or recurrence. I think that's a wee while away. For me, my hope is that women, anybody with breast cancer, including people who are not living in the big cities, have access to treatment and all the support that they need. I feel very grateful that I was in Melbourne when I found the lump. So yeah, I just hope that for people around Australia and the world.
Thank you, Laura. Thank you for sharing your experiences with us tonight. I know that it's a bit confronting to sit in front of a big crowd of people and dig out some personal stuff, but we really, really appreciate you being here this evening and enriching this panel with your insights. I would like to thank all the panellists because we are actually really properly out of time now, but I'd like to thank Anne, Laura, Lesley squared, Nicholas and Hollie for just shedding a bit of light on this tricky, scary phase for plenty of our people who are watching from home or wherever they are, and also those who are watching for people that they love who are going through this experience. I'd like to thank everybody who sent through questions. There were so many of them, so we tried to pick the ones that really represented the issues that people really wanted raised. This Q&A has been recorded and will be available on the breast cancer trials website tomorrow. So the team will send you a link so that you can pass it around to anyone that you think might be interested. Breast cancer trials, and I'd like to thank Breast Cancer Trials for having me here tonight. I never fail to find these sessions illuminating. Breast Cancer Trials is, of course, committed to improving outcomes for every person diagnosed with breast cancer through clinical trials research, and we've heard tonight just how exciting some of those have been. They look to the community too to help support this important research, so if you or your family or friends would consider making a donation, you can absolutely do that via the website at www.breastcancertrials.org.au. They do great work. Thank you again for joining us tonight. I'm going to release you off to your lives. Thank you for participating, for asking questions, and again, thanks to our wonderful panel. Good night. Well done, Tam.